Some of the names have been changed in this video to protect the identity of weak-minded individuals that are scared of taking responsibility for their own actions.
Everybody, well, this clip is basically about what I can, perceive or believe to be pretty shitty service. Now, back on the 29th of May, my wife and daughter were at Green Lane Hospital to get some tonsils out, which they chickened out on. And while I was on my way to come and pick them up from Green Lane, my wife jumped over a fence, or off a metre high fence, and broke her knee.
She jumped off that bit and slipped on the grass.
Is that where you jumped?
Yeah, off the rocks.
Do you want to go and put Mum's bags in the car, please? Here. Go and put Mum's stuff in the car.
Oh, can I keep my handbag?
Sure.
And my jacket.
So,
and scarf.
can you not stand at all?
No, she can,
I can stand.
It's just when she puts weight on it,
Then it
her knee just gives in completely.
because I've tried.
No, hang on, honey, I've got you. Sorry.
It's understandable.
Just over me. You only got me to break, so there's nothing to worry about. There you go.
Thank you.
You're obviously very strong.
Thank
you very much.
No, thank you.
Thank you.
Very much. Appreciate your help. Yeah. Thank you very much. Thank you. She tore a chip of the bone off of the anterior ligament on her left knee, underneath the knee plate, the kneecap. So basically, what had happened is the ligament at the front of your knee that makes you be able to use your knee had broken off and had pulled up 14 millimeters, and she'd also fractured both cartilages on both sides. Now, we initially got x-rays done the day it happened. Then we were referred through to see an orthopedic surgeon, Dr. Incompetent. So we did that. The injury happened on the Monday. We saw Dr. Incompetent on the Wednesday, and he referred us to get an MRI. The MRI was done at TRD in Massey, or TRD in Lincoln Road, on Friday, and then we had to wait until the following Wednesday to see again, for him to say he doesn't want Leah to wear a brace. He wants her to exercise on it daily. He has to do intense physiotherapy treatment for the next couple of weeks to get it up and moving, and that the broken bone will regrow, and basically she would have had a shard of 14 mil extra bone sticking up in the middle of her knee. At this point he said go with physio. My wife, because we live quite a way away, chose to pick another physio closer, Kumeu physio. She took one look at her knee and almost had a heart attack. There is no way you're supposed to move broken bones around. There's no way you're supposed to not wear a brace, because the whole point is to get the anatomy of the knee back to the way it used to be. Not let 14 mils of new bone grow right in the middle of your kneecap, which would have taken months and months of physiotherapy to get back. What she needed was an operation. She needed to basically have the chip of bone wired back down to the other part where it chipped off to close down that 14 mil gap, because if you can think of a rubber band attached to 2 points, and then one of those points comes closer, that rubber band doesn't have the same amount of strength, and that's what would have happened. She's now in a massive amount of pain because she's had the surgery, but would have been far more pain than previous. I placed a complaint through the Health Disability Commissioner and to the medical board, because as far as I'm concerned, we had one surgeon look at it who told us the complete opposite of what should have been done. He caused her undue harm and distress. We had to wait 16 days, and then after the physio saw it, within 2 days she's getting an operation. It had to be done quickly. Not to mention the fact that her entire leg had swollen up from all of the blood that was bleeding out of the bone, and her leg ended up 3 times the size it should have been. So she's on the mend now, but I do not want to see some incompetent doctor like that do something like that to someone else, because now, instead of, you know, what could have been part recovery, Leah's got a more chance of full recovery. So anyway, I recorded the meeting with Jeff after the MRI, where he didn't even read the MRI. He skimmed through it. He didn't even read the radiology report. He drew a pretty picture on a bit of paper for us and bullshitted his way through it. So you can make your own decision. Not to mention, we were there at 11:45, which was when the appointment was. We waited for 45 minutes, only to stick ourselves in the middle of their walkway for them to actually recognise us and say, "Oh, you were supposed to be here 3/4 an hour ago." After sitting there for 3/4 an hour, I found that somewhat insulting. I'm going to actually read the MRI report from the radiologist, unlike what it did. You might note on the top of this form here, it says that it was sent to Westgate at 12:35. Our appointment was at 11:45, and that's when he finally got round to seeing us, after we informed both receptions that we were there at 11:45. But I digress. MRI left knee, indication dropped off 1 metre wall, avulsion fracture on X-ray. Technique axial PS FF, sagittal T1 T2 FS coronal PD and FS. Findings: bone marrow. There is a 14mm wide avulsion fracture in the anterior aspect of the intercondylar eminence of the proximal tibia. This fracture involves the distal attachment of the ACL and the attachment of the anterior root of the lateral meniscus, and these structures are both detached with the avulsion fracture. There is a mildly combined or commuted 20/20 impaction fracture on the posterior aspect of the lateral tibia plateau with minimal depression. There is a further 15mm by 12mm impact fracture on the posterior aspect of the medial tibia plateau with minimal depression. Cruciate and collateral ligaments. The anterior crucial ligament is itself intact, but its distal attachment is avulsed. Normal posterior cruciate ligament. There is extensive soft tissue edema around the medial collateral ligament, but the ligament is intact. This is consistent with grade 1 sprain of the MCL proper. There is, however, a tear of the, I can't even pronounce that one, menisconformal ligament of the deep MCL, intake lateral collateral ligament, biceps, femoris tendon, and libodial band. Sorry if I can get my words wrong. I'm not a doctor. The menisci. There is subtle undisplaced oblique tear of the posterior horn of the lateral meniscus that extends lateral to the attachment of the ligament of Risberg. There is avulsion of the anterior root of the lateral meniscus as described above. Elsewhere, the lateral meniscus is intact. Intact medial meniscus. There is, however, diffused increased signal at the medial meniscus capsule junction without a fluid signal cleft, in keeping with meniscocapular sprain injury. Big words. Articular cartilage. There are small grade 2 articular cartilage fissures overlying the medial patellar facet. Elsewhere, articular cartilage in the knee is intact. Quadriceps, patella, and popliteus tendons are normal. Other. There is a large knee joint effusion with evidence of blood products in keeping with hematosis. There is edema with the proximal imaged portion of the lateral side of the soleus muscle in keeping with a muscle strain injury. Also mild popliteus muscle strain. There is extensive subcutaneous edema. Conclusion. 1. An avulsion fracture of the anterior aspect of the intercondylar eminence of the proximal tibia. This fracture involves the distal attachment of the ACL and the attachment of the anterior root of the lateral meniscus. There also are impaction fractures involved in the posterior aspects of both medial and lateral tibial plateau. Subtle undisplaced oblique tear of posterior horn of the lateral meniscus that extends lateral to the attachment of the ligament of Risberg. 3. Grade 1 MCL sprain along with tear of the meniscofemoral ligament of the deep MCL. Number 4. Medial meniscopular sprain, meniscocapsular sprain injury. The medial meniscapula is intact. 5. Solus and posterior strains. 6. Mild grade 2 articular cartilage fissure overlying the medial patellar facet. The end.
How are you? We were here for the 11:45 appointment for a knee. Knee. We got an MRI scan.
Yeah. It was a bit earlier, but it doesn't matter.
Yeah, we were here at quarter to... It's been here for 3/4 of an hour. Yeah, well, actually 11:40.
Alright, what was your time?
11:45.
Appointment time is 11:45.
Yeah, and we've been sitting in the waiting room. We let them know, then we let them know, then we let them know again.
See, they just shuffle you from waiting room to waiting room, so
That's why we thought we'd come and wait here just in case.
Alright, you better stay in the car and roll on down. Right. Where did you do the scanner? We've been trying to put it down. Was it done at Mercy?
It was done at Lincoln Road.
PRG.
Yeah. We didn't bring the disc, did we?
Okay, that's no problem.
They said they'll extend it to you.
There's nothing arrived in the office, at least as of this morning. Oh, hi. I've got Leah Burnett with me. Has she got an MR come through yet? Did you? Okay, thanks, through. Okay, I'll run up the front and get it. Okay, thanks, bye. Okay, she said it's come through the back at the front. Excuse me a second.
Close.
Say that, that little bit of bone that was abnormal in the middle part of the knee, it didn't look right. It's to confirm that it doesn't look right. It's been pulled up a bit on there, and it's got a ligament and I'll have to draw the picture of it. Cartilage attachment onto it. And not definite about the cartilage on the outside of the knee that may be torn. Vague on that. Right, so you can see this sort of move a little closer. So it's me from the front. I'll come around here with show my hands up to the right, pushing me from the front. Out of the middle of the knee, ligament starting inside and the outside, holding the knee down. Out of the middle of the knee comes the ligament which runs forward. So and the one around the back. Now this one running forward has had a bit of bone which is attached to, just pulled up a little bit, and where the cartilage which comes round the knee like so also attaches to that. So that's where they found the ligament looks like it's intact. They say that there may possibly be tear of that cartilage, not definite, but that's what's happening there. So it's been enough of an injury to pull it off.
So what's the fix?
Just let it take its natural course.
And reheal?
Yep, let it heal. The worst case scenario would be that if it healed, that there was enough of that ligament attached to it, that if it did heal a little high, it made the ligament loose. That would be the worst case scenario, highly unlikely. Even if it was loose, it wouldn't matter unless you were doing a lot with the knee that involved a lot of pivoting and possibility of the knee giving way when that sort of thing happened. It would be equivalent to an anterior cruciate ligament tear, in which case you can just rebuild the ligament. But that's highly unlikely to happen. The most likely is that this is all just going to heal up inside, and you don't need to go after it, you don't need to go poking around with it or trying to do anything with it. You just leave it to take its natural course, and with a high probability of that will result in you being fine. Only question is something like this. If this is real, then that's going to give ongoing pain.
That's giving you a lot of pain, isn't it?
Well, this is an acute injury. This has just happened recently. What I think we should do is go to the HDC, and I apply to them to do what's called the arthroscopy. Even if they approve this, we're not going to be in a rush to do this because I want time till everything's settled down. This is enough to get pain in the knee. But if the knee pain is obviously not settling over time, the question is pain in fact not coming from that? Is it coming from what they're reporting as being a possible cartilage tear? Or is there something else going on in the knee? Either way I need to know it and put a camera on the knee to know. But ACC will take 4 to 6 weeks to make that approval anyway. So we're not in any sort of rush, but just want to get the process there. And it may not ever come that we ever do this. That turns out. But we need some physiotherapy to get going, to get the knee moving, muscle strength up. Even though you might have pain in it, that needs to be managed by medication, just get that under control. But it's to get the knee working, get it functioning. Now that's the important.
Cool.
So that the physiotherapist happens to see what's going on. Fair bit of information.
Yeah.
Okay, look away. We only told you this side of it, so don't worry about what happens through the ACT. It's just that if we get to a point where the knee is not settling down, we've got the option of putting the camera on the knee pain.
I don't know who you are.
Good luck.